Thank you for coming. I am Adam Leventhal, director of the USC Institute for Addiction Science, and really excited today to announce our distinguished speaker, Dr. Mike Stein. Before I begin, I just also want to talk a little bit about the Institute for those who don't know. So first of all, we are a multi-school institute here at USC, and we promote transdisciplinary collaborative education and community engagement, and of course, research. And so we are very grateful to our sponsors, the USC Provost Office, the USC Keck School of Medicine, the USC Doric Peck School of Social Work, and the USC School of Pharmacy. So we are very interdisciplinary here at USC. So without further ado, let me introduce Mike. So Mike, he's from New York, okay? I thought he was from Boston, but he spent so much time in Boston. He went to Harvard for his bachelor's in biology, and then he got his medical degree at Columbia. So yeah, he's like a smart guy, very well educated, but he did tell me earlier today that he went to Caltech and started doing some work in biology, and he was intimidated by the folks at Caltech and how smart they were. So, that's good to know that, we have that here. So anyway, so he went on, he did his internship at the Boston Medical Center and specialized in internal medicine. And also, I think he's boarded in geriatric medicine as well. And he's an award-winning author who's written popular media books on the intersection of health and social issues in the addiction area, and then also other areas. And he has a brand new book that just came out. I forgot the title, but you should all check it out. And in terms of his science, well, first, let me just tell you a little bit more about where he's at. So currently he is the chair of the Boston University School of Public Health. He's the chair of the Department of Health Policy. And previously he was at Brown Medical School for a very long time and oversaw a number of different clinical and scientific initiatives there as director, including overseeing HIV, the HIV program for patients and clinical services at Rhode Island Hospital, and also addiction research at Butler Hospital. So now in his role, he's taken a much broader view in terms of education, science, and also interacting with the public. And he's participating in the NIH HEAL initiative, which we'll talk about. And Mike is very well known for his decades of research on HIV care. He was one of the first folks to start thinking about addiction medicine as addiction medicine. It's not necessarily just a subfield or a niche in psychiatry, but something that should be integrated within primary care. He's done a lot of clinical trials for people living with HIV, people with opioid use disorder, looking at ways to increase the effectiveness and the reach of before we called it medication-assisted treatment, which we now do, in terms of medications and opioid agonist medications to save people's lives. So we're very excited to have Dr. Mike Stein. Welcome.
Thank you. Can you hear me? Thank you very much. When somebody says they're taking a broader view, that just means they're old. I think Adam just said I'm getting old. So I'm going to talk about a fun thing that I thought isn't really so known in the West Coast. So I thought I'd bring you a project that's ongoing. Mostly it's sort of the setup of a project, tiny bit of data at the end. Questions anytime you want, interrupt me. This is one of the projects that I'm doing, and I'm honored to be here. I'm honored to be here in person. I was going to come last year, but I said no. And then I was put to Zoom, and I said no more Zooms. I have to come out. I want to come out, so I'm glad that you all came out. So you have heard of the HEAL initiative, which is something that the NIH has been plugging for a number of years. And this is a big randomized study. Has anybody heard of this giant study called the Healing? You've heard of this study? Anyway, it's a large 67 community study. It's not like anything I've done. So I've done clinical work, I've done health services research, I wrote some of the initial studies about HIV in women way back in the day, so clinical epidemiology. I've done intervention research, but then I thought, okay, this is a whole new thing, doing community engaged research, which many of you do far better than I. So I'm a beginner at this, and I'll tell you the parts that have been interesting to me along the way. So let's just get going. Okay. Click this, touch the screen.
I was messing with the Zoom before you got it.
Okay.
Sorry about that.
It's okay. Next.
Okay, so basic stuff, study scope, the communities that heal intervention, the so-called CTH intervention, reduction strategies, a little bit of social justice, and then some data bites. So this is what happened in 2018. The NIH put out an opportunity to test the immediate impact of implementing an integrated set of evidence-based interventions across healthcare, behavioral health, justice, opioids in highly affected communities. And what they said was, we're only giving you one per state. So come in as a state and apply. So there were 25 or so states that applied. Some states, of course, that were big states split them. I think California might have put in 1 or 2 applications. Maybe you know that. New York put in a couple. And they ended up funding 4 states, all east of the Mississippi, sorry. And that's why I figured you might not have heard about it, to work with 67 communities in those states. They committed $350 million, which was really amazing. Massachusetts got 90 million of those dollars. And the partnership, therefore, was between academic institutions, which were Boston Medical Center or Boston University. Those are sort of related on the same campus institutions, but of course, financially separate to make it interesting for everybody. And these other places, all of which had a academic home, but also community-based homes. So it proceeded. So this was the Healing Community Study, and there were communities picked across the 4 states. These were 4 states that had to go in and presumably had high opioid overdose death rates at that point. I haven't shown you the goal of the study, but it's obviously about opioid overdose reduction, because in 2018 we were seemingly peaking. Of course, we've now seen things that have gone beyond that peak. There were 4 states that had these towns. So they had to be both urban and suburban and rural communities that were in the towns. The towns were going to be randomized. Each of the 4 states put in their own application with their own study design. The study design was then post hoc decided by NIH that the study design had to be the same across the 4 states. Well, that drove us in Massachusetts, of course, crazy, because we clearly had the best design, and that we weren't going to have the best design to go everywhere, or just leave us alone and let us do our thing. I mean, we thought it was a big mistake, and I can tell you now, 3 years into the study, it was a big mistake. They should have gone 4 different ways, but they forced us all into a similar situation, which forced the states to talk more, which has been an interesting thing in itself. So here are the states, just so you see where they were. Ohio was a late addition with the biggest population and the most overdoses because they needed numbers. So they were the last choice here. It's about 10 million people. Those are the overdose death rates by community. The communities, as you see, are pretty well split. They were all expansion states, and we could talk about that. And again, those were the numbers headed in. So Massachusetts were these towns. If any of you from the East Coast, Massachusetts, so bad that the Celtics lost last night. You'll see that the Boston is not here. So towns that had a lot of activity around reducing opioid deaths were out. So that was decided in all the states. The big towns were out. So we went to these other towns, including places like Cape Cod, the western part of the state of Massachusetts is actually quite rural. There were rural communities, and then it was split up into so-called Wave 1 and Wave 2. Wave 1 were those 8 of the 16 communities that got randomized to receive the intervention. Wave 2 was told, wait. So an interesting political issue. You will get money to do an intervention after we do the intervention in the Wave 1 communities. That is, you are our control communities during the period of evaluation, but you've got to wait. So that, of course, when the coin got flipped and you were one of the 8 communities that told you to wait for your money for the next 2 years and therefore proceed on your own and therefore might not have much expectation of reducing opioid deaths, we had a lot of unhappy people. So the politics of that was interesting. So what is this? This was a study to reduce overdose deaths. This is a giant study. This is a randomized clinical trial. This is not a service provision trial or evaluation or implementation study. It was a randomized trial. So it's a 5-year multi-site implementation research study that will test the impact of the communities that heal intervention compared to usual care in the parallel arm cluster randomized waitlist control. So those were my eight controls. And the coalitions of these HCS studies, of the general study, were to pick from 3 evidence-based interventions. So the notion was, academics have been working out interventions for the past X years. We want to bring the best to the table out into the communities. They don't have them, they don't do them. We're going to deliver them, but you're going to have to implement them, right? So, and can you implement them, and how do you do it? So the 3 general categories of reducing opioid risk, and the goal, so the study was powered for a 40% reduction in the intervention arm compared to the control arm during the evaluation period. That's a huge reduction, and I thought completely unreasonable, but that's how it was, that was how it was set. And we could talk about whether at the end, if you get a 12% reduction or something, and there are no results, so I'm not going to hold back anything, but there are no final results on this, and I'll tell you where we are in the process. But is 12% a successful study, or is it just a study that didn't hit its power targets? So the strategies were, well, you should be giving out naloxone. We know that's life-saving. We should put people on medications. We know that's life-saving. And you can improve opioid prescription safety, which was pretty much happening in the background anyway by 2018, right? The medical community knew that overdoses were high. They sort of understood that they were to blame, and they had already started changing things. So that didn't become a focus of the study. It dropped away pretty quickly because we felt like even in small towns, it was sort of happening. Everybody was aware, like, I should be prescribing fewer opioids, which has generally been the trend, although not perhaps as much as any of us would want. So that was the study. The intervention came in 3 parts. 2 of the parts were the one on the left, the opioid overdose reduction continuum of care. And that's these evidence-based strategies. Those are things you want to actually get out into the communities. Well, you had to do that through community engagement, which has its own science and its own processes and its own time frame. And those of you in the room who've done it, and I had done a little of it, but nothing at this scale, was hard. The communication campaign, which is how I got involved, because there were younger people who could do the EBP, the evidence-based practice stuff. Although I had developed some of them, I thought, I'm not interested in that anymore. We're going to do communications. The NIDA RFA that put this out really almost didn't mention the word communication in it. It had no requirement to put in the grant, which is sort of shows you the difference between academics and the rest of the world, right? It was nowhere, but several of the states, and I was one of them, and I said to Jeffrey Samet, who is the PI of this grant, I said, you know, you're going to build these things and nobody's going to come. So you need a communications arm, and I'm going to write you a communications arm. So of the 800-page grant, I wrote a 1-page communications plan, and Kentucky brought in their School of Communications, and they wrote one, and the other 2 states basically didn't have a communications plan, and it wasn't part of the reviewers' review criteria. Well, luckily we had set some money aside because it became one of the 3 arms of the study, because relatively soon after, people understood this is going to be a key element. So here is the study timeline. It's complicated and it's moved in time because of the pandemic. I got like 8 slides in, I didn't use the word pandemic, but of course all of you who do research have known that the last 3 years have been bizarro and difficult and slowed everything down. So wave one at the top started to happen really in 2020, but in early, there was startup, there was hiring, and I'll tell you who was hired in 2019. Beginning of 2020, we were supposed to do the wave one starting really out in the communities. And of course, 3 months into 2020, we were done. It was very hard to try to proceed on Zoom, but we did as everybody else did. And some in the community as well. The usual care, those 8 control communities are wave 2. Now, if you look at the very bottom, the comparison, CTH versus usual care. So that is a period of time that we are in right now. So we are in the evaluation period. So all of the time that came before here, all of this period is actually implementing the intervention, getting it up to full speed so that when the clock starts during this period of time, that's the evaluation period where we're looking for that 40% reduction, okay? It wasn't a 40% reduction when the study got funded. It was, we're gonna start a period of time, and that's where the comparison is gonna be. So the comparison period ends on June 30th, and on June 30th, we'll have collected, you can't do it really in real time, but all the overdose deaths and overdoses and all the rest of the data and compare the two sites. So we're at the very end of the evaluation period. At the end of the evaluation period, as you see, the wave one communities lose almost all of their money because they've gotten the money to set up these evidence-based practices, and wave two starts, and they have a bit of more contracted time to get these things up in the air and going. And why is that? Again, they were both delayed, and they get less time, and they get less money because they get less time. So they were, in general, unhappy group. But because we hope we've learned something from wave one, we think we can get up and going in wave two much quicker. Although you still have to build coalitions, which is always the time limiting factor. And but we think we can do that faster. And then they get a bunch of money now to bring in the practices from wave one. We hope that this group continues forever to use things they've learned in a sustainment phase so that they can, a maintenance phase that they can use going forward. So here are the teams that we set up to do this. We have an informatics core, the community engagement core that deals with the people in the community, a health economics core, which captures the cost of every single tiny thing. I get an email every week, how did you spend your week? How did you spend your time? And we have all of the people on the staff and all of the people in the community sort of adding up our hours. The care continuum core are the ones who actually bring the evidence-based practices. There's a communications core that I run. This implementation science core does its thing, and then there's an administrative core. So that's the team. They're employed in the community. I'll show you very quickly what that looks like versus at the university. There's a community advisory board for the entire study that included people from all the communities and some at-large members, and included lots of different kinds of people, including people in recovery and family members, et cetera, et cetera. So that's the community advisory board. That was really the first thing that was set up, and we often turn to when we have trouble or we need communication. So this is an unusual study. It's historically large. It's designed in partnership to be implemented in local communities, and it's meant really to be a way to find implementation strategies on this ongoing problem that can be brought to other communities outside of these 4 states or inside these 4 states. The study moves through phases. I'm not going to spend a lot of time, but preparation, getting started, getting organized, doing action planning, et cetera, et cetera. So we have to build this out, really step by step, and it takes a lot of time and eventually get to implementing and monitoring, but everything is cataloged, manualized, et cetera, so that all of this can be given to, Pasadena. Where there's an issue, I guess. The communities are communities. Sometimes they're a single city. Sometimes if they're rural, they're groups of communities. Massachusetts is pretty small and rural, and so we had groups of communities in R16, but the others had counties. So you could do it at a county level, you could do it at an individual town level, you could do it at clustered community level. So again, we try to bring real world implementation of addiction treatment through community coalitions, through funding and technical assistance. And then a key element that I haven't mentioned is the bottom, which is state Department of Public Health officials. And they give you the data that they have on overdoses as much as they can in real time. And it depends where you are in the country and how that can happen. And they can make policy changes happen that we thought were absolutely critical. So we went into this, with the imprimatur of the Department of Public Health. And so I'll tell you how we made use of them as we went through time. The high-risk populations are those who you can imagine, but there may be more than that. And the question is really, how much time do you spend? There are people who use opioids, there are people who've had overdoses, they use other substances. But people were dying less of other substances until really fentanyl entered other substances. Then all of a sudden they started dying. So our so-called opioid study, should it be in 2022 turned into a stimulant study, right? So you had different issues here than we did. There were no stimulants in 2018 in Massachusetts. That was just not an issue, let alone fentanyl in a stimulant. And now we have a different thing. So if the intervention goes down as a negative study or as a study that doesn't match, it could be because we missed the boat, because all of the things that we focused on were related to opioids, whereas people were dying with fentanyl in their cocaine and never thought of themselves as having an opioid issue. So these other substances became important. Obviously, mental health and medical illness matters, and then there are special populations. How do you reach people? We asked ourselves early on, and they were going to be in criminal justice settings, syringe services, EDs, mental health treatment, primary care. Can you reach through the pharmacies, social service agencies, out in the communities? And how do you use first responders, who are often people who are offering them naloxone in most cases? So I'll talk a little bit about Massachusetts. So in Massachusetts, this is how we set up each of the 16 communities, just for those of you who are interested in sort of the technical pieces. There's a community facilitator or community coordinator, a data manager, a community faculty person, usually an MD who can talk to and teach other MDs in that community about what we're talking about, and then setting up a office-based addiction treatment nurse. So these were things that were built into the budgets of the communities. And some of these were based at BU, some of them were actually based in the communities. The community engaged facilitator was really sort of the orchestrator, the conductor of the whole business. This was an important person. If there were a lot of turnover in this, you were in trouble if they were turning over. Most of these people have stayed for most of these years, so that's been great. They would put together and convene the coalitions. They would support a landscape analysis. What services do you have? What might you need? Who's dying in your community? They'd guide the coalition in developing a charter. Each town had its own charter. They would pick strategies and they would facilitate the implementation. And then they would be the liaison between the community and the academics. The communities got about $1 million a year to do what they wanted to do. So each of the communities get $1 million or so, and they're literally handed like, here's your menu, right? Do you want French fries or do you want naloxone? What do you want? And so here's what we offered them. These were the selection of evidence-based strategies. They were given them in the 3 categories that I've described. The naloxone, the MOUD, and other. They were to be engaged in data-driven decision-making to select those based on their community needs. But in general, they were universalized. So all of those 3 things mattered. And then the coalitions were supported by experts. So here was the menu. So the first menu item had to do, and you could pick a bunch of things from each of the menus. Each of them came with what we estimated the cost would be for your community. So if you were going to do, a high-risk venue, naloxone distribution, I'm making this number up, that will cost you $20,000. So now you're down to $980,000 from your $1 million. And if you want to hire a nurse and set up a new program for offering medication, well, that'll cost you $130,000. So now you're down to $850,000, et cetera. So we really would sort of walk them through a menu based on what we thought it was going to cost for doing this. So they would have naloxone. Who would you give them to at risk, or their social networks? Not the same, maybe different advertising strategies. How do you reach people who are hidden populations versus their parents? Slightly different. Where do you do it? High-risk venues? Do you do it by prescription? In Massachusetts, you can walk into any pharmacy and buy naloxone anytime you want, as without any questions asked, because there's a sort of standing medical order in pharmacies. What do you do with, where do you put these nalox boxes that are expensive? Okay, so here's an example of one town in Massachusetts, and I've given you Massachusetts examples for what they do. This is a town of Holyoke, which is a rural town, which is about a 45% Hispanic town, Latino town. And they wanted to expand their services. And so we worked through an organization called Tapestry Health. This is mid-pandemic. Okay, so we are in the pandemic trying to get people to do these things. They hired a full-time harm reduction specialist who just did street outreach. Another town, Brockton, might not have hired that same person. This town decided, based on their coalition coming together and talking about what they needed with our help and our menu, what they do. And in the year that I'm giving you data here, you can see about how many people came to trainings, how many people came to get kits, how many peers were, and how they did it. So another naloxone example was our town of Lowell, where again, the Massachusetts Department of Health had a leave behind program where naloxone was left behind at any overdose call, regardless of EMS transport refusal. So if you pick the person up, you would still take and hand out naloxone to anybody who was on the scene. If the person refused, you give them naloxone, anybody on the scene. The EMS crews provided overdose education, et cetera. So this was something that the Department of Health, to sort of infiltrate the EMS system and say, this is the new policy, means you need partners who will make that happen in the EMS program. So again, it's that sort of academic, real world partnership. And again, here are some numbers from 2021. The second item of the menu, so the first item was naloxone. Now we talk about delivery of MOUD, and that was setting up an OBOT, or an outpatient service, or an opioid treatment program, which is sort of a name for methadone programs, or setting up bridge clinics. Where do you go for an emergency room, but you can't quite get an appointment in the methadone program? Can we set up a clinic for that week or two before we get you going? Can you start all of these things in the emergency room? Well, you have a sophisticated emergency room because you're in downtown Los Angeles. You guys do this, but if you're in Holyoke, your emergency room docs don't know necessarily about offering buprenorphine in the emergency room, so that has to be trained. There were inpatient addiction services that were created. We use peer navigators, et cetera, et cetera. So you would then hear from people about, what was happening in their communities. They'd say, listen, we have a program here, but, Holyoke would say, we have people who are overdosing in Holyoke. There's one methadone program, and the overdoses, people don't go there because they put this methadone program out in the outskirts of Holyoke, and there's no transportation. The bus line's terrible. Help us. We don't really have a medication program where the overdoses were. And we said, well, really? How do you know that? And so we went and got the data, and we found out where the people were dying. And it turned out that the existing OTP program was in fact way out here, where there weren't people dying, and that in downtown Holyoke is where people were dying. And so we brought in our state health department partners and said, how fast can you set up a methadone program? Well, in Massachusetts, that can take years, if ever, to set up a methadone program, except if you have the State Department of Health on your side, and an understanding that we need to do this because it's a randomized trial and we're going to be evaluated fast. So they came in and they put first they gave us the data to show us where people were dying, not so easy to get in many places, and then we built a methadone program, or the coalition itself used this money and built a methadone program in downtown where the deaths were. And in the first year, we funded a nurse practitioner, a nurse, a care coordinator, a recovery coach. They put a lot of money into a methadone program. Methadone has a bad word on the street in lots of places, but of course these days it has a good word or a better word on the street in a certain sense, because buprenorphine, which has been the favored child for medications for opioid treatment, has fallen hard a little bit during fentanyl. It's easier to sort of use methadone, transition onto methadone if you're a fentanyl user. So methadone all of a sudden was making a comeback. They put this in. And again, you see, you pick up 275 people who weren't in care in that year. Half of them are Hispanic, and then they're retained. So if you're thinking about overdose, right, you not only have to prevent overdose with naloxone, you then hope you get that person into care. So that's good. That was built into our power calculations, how many people would get into care. But then they have to stay in care. And that's a tricky thing for anybody who, as you know, who is in addiction treatment. They don't stay in care. And 63% at 6 months is about the national average. You need high rates of people, presumably if you're in care, therefore you're using fewer drugs and therefore not at risk for overdose. So all overdose prevention programs need to not only think about initiation, but really need to think about retention, which we built in a bit into the power calculations, but probably we needed to do more. And really there's no universal way to keep people in care. Like that's a great research project for all of you in the room who are looking for projects. How do you keep people in addiction care is a great question. Even when you have a medication, as you do with opioids, which you don't with stimulants or something else. Interesting question. Brockton set up, as another alternative to this, they set up a mobile health unit with a pickup truck and supplies and staffing. And they went out and they found people and they distributed naloxone and they did a variety of things. And that was good. They went into populations. Most of the people in Brockton and care were white. They went out and found people who were Black. That was good. Bourne Sandwich, which is near Cape Cod, did another thing. It set up its own Office of Addiction program, which offered buprenorphine and injectable naloxone, and they did. So I'm just giving you a little sprinkling of what people use their money for. Lowell General set up a bridge clinic for low barrier access. Lowell General also set up an inpatient consult service. So all of these things were not made up out of the blue. We had done, or we and other people around the country have done studies, clinical trials over the years to show that addiction consult services seem to help. And bridge clinics that are low barrier entry seem to help, and et cetera, et cetera. So these were so-called evidence-based practices that went into the world. This was one of my favorites, which is Gloucester, which is one of the famous old whaling towns, a fishing village right on that water. You know, people would go out to sea for weeks and months, and a lot of them used substances. And so we actually did outreach at the docks. So that's been an interesting project where people would be linked to care, initiated care with an understanding of long-term prescriptions. Safer prescribing, I'm going to pass on. These are things that you know about: acute pain prescribing, chronic pain prescribing. How do you do it? And we didn't spend a lot of time on this because, as I said, it was already being done. So as you can see, our strategy of implementation was there were tens, dozens for each town, for each state that were offered. Here's our shopping list. How many do you actually get done, right? We're going to give you some money for each of the things, and Brockton has 12 things on its list, and Lowell has 20 things on the list. How many actually get implemented? And the answer is a lot. Like if you have it organized and you have a coalition and you have staff and you have money, most of the things get implemented out in the world. So of the overdose education distribution, 90% of those got implemented. And there can be several in one town. Medications, we were pretty good. Safer prescribing, we tried and was pretty good. So that's good. So we were very happy with implementation. This is all like rosy, right? This is all like, I don't know whether any of this worked. We're in the evaluation period. So I'm trying to show you that, you know, you spend a lot of time on this, but in the end, you don't know that it works as you're going along. A piece that I worked on was were the communications campaigns. And I learned a lot about communications from some communication school experts from around the country. And we devised with some vendors our own communications campaigns. So states are doing their own things, right? They're putting out billboards, et cetera. We decided we would do ours that would focus, because when a state does a campaign, it does it for the state. And we needed to have campaigns that were targeted to just the intervention towns. So we didn't want even a radio ad that would go statewide and affect any rates of overdose. I say this as a researcher, not as a human being, but as a researcher, I don't want my control towns to be changing very much. So we had to create our own campaigns that we targeted into the communities that were the active ones. And we decided on 4 different campaigns, and these were, the order of them were decided on the communities across the country. So we decided as a group, as 4 states, that all of the countries, the first campaign would be naloxone campaign, and we would devise naloxone campaigns. And then we would do a stigma campaign. Everybody wanted to do a stigma campaign. That was the #1 campaign. And I have to tell you, I have done this job for a lot of years, and I don't know what a stigma is. I really don't know what that is. All I know is that it's really hard to change stigma in a community, let alone a state, let alone a single hospital or any place else I've ever worked. Stigma is super hard, very popular, very popular. I think really important, but just sort of understudied, and I don't really know what it is. So everybody wanted a stigma campaign. We tried to do a stigma campaign. There was an MOU awareness campaign. How do you initiate? Then we had a stay in treatment campaign, so that retention problem, that was targeted right to people who are already in care. So that's a much finer campaign. You want to get that to family members or clergy people who can support the person who's already in care, and you need to get it to the care providers, as opposed to an MOUD awareness campaign where you're trying to find people who maybe have thought about going on treatment before but haven't quite made it in. So there's different target audiences that we did. So we built out our own campaigns. These are our own things. These are often pictures of people who live in the communities. The communities could choose to substitute. We had a variety of pictures for each of our campaigns, and they could choose to include photographs of people in their community or not. You didn't have to. It's tough to make that decision if you're a person who uses drugs, right? Because once we make a digital ad of you, you're going to be out there forever as that person. So those are large consent forms that people had to sign to be on. But these are real people in many of these communities, and we made them in multiple languages. We did them in Spanish. In some places, we did them in Hmong. We did them in Portuguese. We did them in a variety of places, and we would put them out into the world. So we would put them out on billboards. We would put them out on park benches. We would put them on bus ads. We would go on the radio if we felt the radio was very local. We would put them on PSAs. We would get people to write about them as op-eds. We had clever things like some towns decided we can put these ads in utility bills. Everybody in our town gets a utility bill. So we would put them in utility bills. So there were a lot of really clever ways to get these out there. And our biggest pushes would be around digital, because that's where people are going. And if they're hidden, they're probably checking their phones and their internet sites anyway. So we had small budgets compared to the state, but we targeted them. So what do you do when you make an ad? Well, there's always a call to action at the end of an ad, which is, right, you know those ads, you pass them on the billboard, call 1-800 blah, blah, blah. Or in a digital ad, here's the link, go. And so we built for each of the towns a website, which would serve both as a resource of information for anybody who went to the website, but also would be our link to know whether they saw the ad, because you wouldn't get to the website really without going through the ad. And we would see whether the ads would spike interest when we would plant the ads, send them to the resource. Now, the downside to that is, you don't know whether they completed the circle. They went to the ad, they saw the ad, they went to the site, they saw the site. Did they ever get into treatment, and what happened to them? So we don't know. It's the same. It's the hotline problem. But so that's interesting that that's how we build it. We had a lot of interest in racial and social justice issues right from the beginning. As I said, we had multilingual communications campaigns. We were very aware of our staffing. We partnered with local organizations, and so that was interesting and important, and obviously over time has become of the moment. But we were sort of a little bit of ahead of the curve on this one because you're in the communities, and that's who lives in the communities. Quick data bites, and then I'll take questions. So this is what happened in the 16 Massachusetts towns. These are the little bits I'm allowed to share with you. I can't share much of the data because it's sort of privileged at this point, but you see the overall opioid death across the 16 communities. Again, this is not broken by control or intervention, so it doesn't give you any sort of information, but it was pretty flat in the early part of the epidemic. Unfortunately, the numbers of opioid overdose deaths in America keep rising, including in Massachusetts. So in fact, the numbers have gone up in 2021. And the question is, did they go up in our intervention communities equally with our other communities? So what we could see along the way over these 3 years were some racial differences. And we were, very disturbed by the middle column, which was overdose deaths, opioid specific overdose deaths in the 3 years. And you see the Black numbers rising across the 3 years. Now, these are, if you look at the bottom, very small n's. A small number of people are going to shift these numbers, so it's hard to get super panicky about them. But that's what trends are for over time. If they keep going the wrong way, even if the numbers are small, it makes you worried. But a lot of these things then drove us into the towns where there were larger Black populations, and we said, like, what's going on? Like, why can't you reach your Black populations? Can you help us do that? What's the best way to do that? And we tried. So that's where that happens. That's a teeny bit of data. And when we would do it, for instance, a high-risk population, we zeroed in. Again, this is what having the Department of Health on your side and a data team all the time is, that you could see that it was really Black men in 2020 who were suffering the greatest increase. And how do we do that? And among the Black men, it was partly Cape Verdean. And so what do? This is what we did. We collaborated with the Cape Verdean Cultural Association. There was a Black-owned business association. We got them involved. Does it reach the right communities? Does it reach into the hidden populations? I don't know. But that's what you can do when you're in the communities, and if you know the communities well enough. And my question is always, do you know the right person in the community, right? There could be that one person who has a loudspeaker and reaches a lot of people. And if you don't find that woman, you're done, even though you think you're doing pretty well in that community. So that's tricky. The impact of COVID on buprenorphine. This is interesting, which is that these were the numbers. Buprenorphine was going up from 2018. That's good. That was a sort of expected secular trend. It continued during the early years, and then things dropped off from the advised, when people stayed home. So the dotted line is where we would have thought it would go. That was our estimation of where it was headed. The dots on the right-hand side of the vertical dotted line shows you where it actually went. And so fewer people on buprenorphine. That's not good for your overdose numbers overall. Again, this is all 16 towns. And remember, we hope that this would be better in some places where we're building out new capacity for treatment. But in general, the pandemic didn't help buprenorphine. On the other hand, the pandemic probably did help methadone, partly the pandemic, partly the fact that methadone programs, both federally and locally, changed a lot of policies so that there were take-homes, where there didn't used to be take-homes. You were expected to come in every day in methadone. Here you could do take-homes. And again, we made some progress, we think, again, by setting up new methadone programs, and perhaps fentanyl pushing people into methadone rather than buprenorphine. So we published some of this stuff. This is a special issue of Drug and Alcohol Dependence that came out, where everybody put in, there was a communications paper and a coalition building paper and implementation science. So this is sort of an overview if you want to read about sort of the general structure of the study. There was an issue, 6 months ago, and here's the 7,000 people who've worked on the study. And I'll stop and take questions and give you a chance to ask me what you need to, but that's a sense of what we've been doing for the past couple of years. Thanks. Hello.
Hello, this is an incredible.
Who are you? Tell us who you are.
John, not personal.
Oh, great.
So, as you described it, there's quite a bit of flexibility that's given in terms of what gets implemented, which I understand there are benefits of that. Obviously, it's scientific challenges that brings up. So, I guess, to what degree are you positioning to make inferences about specific programs versus the easiest thing to make inferences about is like, if we did this sort of thing where we give this much money to communities and this much flexibility,
Yeah.
then we got straightforward inferences that can be drawn. But individual, how do you
Great
think about
question.
those two issues?
So the question was, is there any way to disentangle any effects that you might see at the level of the program? And the answer is no. In fact, they're really not going to be planned analysis. The 40% reduction is all wave 1 communities versus all wave 2 communities, right? It's not going to be perhaps just the rurals versus the rurals, or the best versus the least, or the largest. So first of all, it's aggregated at that, at least originally. And I think it would be hard to break it down much below that, given the size of Massachusetts, maybe in a bigger state with more overdoses, perhaps. It is a package. I think you will hear this as a package. So the question then is, well, is that generalizable, right? And I don't know the answer to that, because the package, as you said, is going to differ by town. So there may be, in the end, some detailed implementation science work, some qualitative work that will give you a sense of that. But I don't know that there's going to be any other way other than that to disentangle.
Is there any sense that there's political will to potentially be generalizing that the package of options as a policy matter? In other words, is this potentially leading to, okay, we know if we did something along the lines of what you all did at a state or federal level, we'd see, in the fantasy that things come out right.
I don't know how, they spent Nida spent a lot of money on this, and Nora Volkow is like deeply involved in a lot of the details. So whether she decides to bring this to the congressional floor and say, we had a 17% reduction when you institute these packages, here's what it would cost to implement it in Louisiana. I don't know. You hope so. But, these political things are short, right? When if opioids tip down, I don't know what happens then. So.
Can you speak a little bit about your working with other states and things they ran into that they learned that helped you out, vice versa?
Yeah, I mean, it's strangely different state by state. So it really becomes sort of programmatically on the ground what works. How do you do, and who do you invite to a technical advisory committee? How big should that be? What the coordination should be? But New York and we are very different. New York has a very aggressive Department of Health. They're set up by counties, so they're organized financially differently from us. So it was very hard to make a lot of sense macro, what we learned from states, but since every group, right, whether it was the care coordinating group or the communications group or the implementation science group, they're meeting with their counterparts across the 3 states. So there's a lot of exchange of information with them. So we say to them, have you ever thought of putting things in your utility bills? And they, well, that's a great idea, and they say to us, here's the vendor we use for getting on, radio in this particular way. And so I guess that's how I would say, very little macro that I can tell you about. I mean, the decisions are made as a group, so there's general compromise at a lot of levels. Hi.
Hi, Lindsay Richardson, visiting here from the University of British Columbia. And my question follows on John's a little bit, in that I'm really curious about what the actual research question was. And the reason why I'm curious about that is because we've got 3 interventions, all of which have an existing evidence base. We know that they work, and so it seems like the study itself is a study about how those interventions are rolled out in context.
Right, it's an implementation study.
Right?
Yep.
And so my question is really around, like, what's the primary research question?
40% reduction in wave 1 versus wave 2.
That's, for me, that's an outcome, it's not a research question.
Oh, you mean why would a community engaged approach, does a community engaged approach to delivering a package of opioid overdose reduction interventions work?
Okay, so the research question is fundamentally about the community engagement process. And
Yeah,
not
I
necessarily
think-
about the interventions.
I think so. I mean, I think, as I said, it wasn't an invention of new engagement. It wasn't of new protocols, right? We had protocols that within individual trials, but not at this scale work. So it's an implementation study.
Okay, and it's about the community engaged implementation of interventions that have an existing evidence base.
Correct.
Thank you, that's fair.
I think very important to mention the qualitative part of this as an implementation study, how critical it is for community-based research. And so that's like the details, the devil's in the details. So one detail that struck me right at the beginning was the really high ODs in Massachusetts compared to the other states. Do you have any insight on that? Why such a large difference? I mean, is it a statistical artifact, or is something about context? I mean, I love what you said about Plymouth and the port going out to sea. Is it something about Massachusetts context?
I don't know that it's just about Massachusetts. I mean, there are rates high in New England, and there are rates high in different parts of the country. I mean, you know better than I, there are these strange epidemiological pockets of these problems, right? Why wasn't there ever HIV in Denver? Like, why? What is that? There are these things that are very hard to understand. New Orleans, very low HIV rate throughout the HIV worst years. Strange. So I'm not sure. It probably has to do with fentanyl supply, is my bet at this point. I mean, which pretty much explains a lot of bad things that have happened in America, is the fentanyl supply. I mean, my interpretation of sort of deaths of despair, that phrase that has come to interest everybody, is basically just a fentanyl death of despair. I mean, it's not framed in all of these other ways, but it really tracks fentanyl. So, yeah, I don't know the answer.
I think that, again, this is, so much of the OD data and everything is numbers, is quantitative, but I really think there's a dearth of really qualitative work in actual cases.
Well, I'll tell you just one tiny little qualitative thing that interested me. So the study was built as a research study. Again, if I took my research hat off, I wouldn't have built this study in this way. But the study was built as a research study. Oh, now I forget what I was going to say. Yeah, sorry.
It's okay.
I'll come back in 1 second.
All right, so we have an online question.
Okay.
So it's from Brian Morris. Thank you. So Brian says, I'm a peer recovery coach on Martha's Vineyard. The opioid struggle is real here. In my experience, particularly amongst our Brazilian population, community spiritual leaders are of great value. Spiritually being the cornerstone of some people's recovery. Did the HEAL Initiative invite spiritual leaders to the table?
Yeah, very, very much. They were part of coalitions at individual towns. There were spiritual leaders. I can think of 2 who were on the sort of community advisory board. So yes, they were definitely involved.
Thank you. And, go ahead.
My name is Anthony Mario. I'm actually from Florence and Lowell, so this is
Yay.
really interesting to me. And I think compared to the other states in the study, Massachusetts has this geography problem. I'm just curious, I don't know if you're there yet with the study of how you're attributing the intervention effect, because it's a very condensed geography. It's at the municipality level. These people are very global. So say someone is doing a lot of, buying their drugs in Lowell, doing their drugs in Lowell, but then they travel across the border and OD in New Hampshire. How do you deal with that?
It's a great methods question. And we've thought about it a lot. It's not that they don't go to Lowell, it's that they go to Brockton.
Yeah.
So they're counted on where they live. That's how they're analyzed, by where they live, even though they might get treated out of that city. That was the decision that we made.
Cool. Thank you.
I'm very bothered that I can't remember what I was going to say. Go ahead. Hi.
Go ahead.
Hi there. So I have a question about the team that you guys formulated within the communities. So, for example, the nurses and the individuals who are interfacing with the communities. What, if any, was the consideration for hiring the individuals and like curating that team?
You mean who hired them?
No, like for example, like to pick the nurses and like all the individuals working within the regions.
So I'll tell you a little bit about that. So the community would get their money. They would set up the programs that they want. Each community had what we call the financial anchor agency that handled the money, even though that money might need to be distributed across a variety of vendors or players in that community. So if the money went to a community health center of city number 1, they would hire who they wanted at their level. So there were research project people who were based in Boston, and they were hired by the researchers, and there were community-based people who hired the others. So we did not have anything to do with the hiring at the community level. It was left to the people who had the budgets to do that.
The reason I asked the question is because I'm thinking the people who are community-based might have an actual impact on adherence or
Very much.
the way in which the results pan out.
And so I think I remember what I was going to say back to Professor Kaplan's question, which has to do with our advertising. So that here's a qualitative study that we did that we haven't published, but we had the original ads would send people to the resource that we created at the website at the community level. Well, again, if you're a person who's looking for treatment, that takes you a lot of clicks to get through that to the place that you actually want to treat. So this last campaign that we did, which is in the field now, said, well, we want to put the actual name of the organization on the ad and their phone number, like you often see. To do that, to make it change into the place at the community level was apolitical, number 1 political, which is like who gets to choose which phone number goes there? Is it that anchor agency that has the money? Is it the coalition? Is it somebody else? How do you do that? And then they provide you with their top figure. At that point, I thought, well, before we spend $100,000 on this, we should do a little secret shopping. So my staff would call all of the numbers at all times of day to see what happened posing as a person who needed treatment that day. And it was like a disaster. It was like you would get these places, and it just shows you how hard it is to be consumer friendly in this world. It's super hard. And you would get this information, they wouldn't pick up the phone, it would take 3 clicks to get to somebody, they wouldn't know whether they had naloxone, did they provide methadone, did they not? And so then you put these ads up with the numbers on it, with the best guess by a community into an imperfect system. So that's like a super interesting, just qualitative sort of little secret shopper kind of checkup on this. And that came, we're now 2.5 years into the study. Why didn't we ever do that earlier? That we had to learn this 2.5 years later, should have been a quality assurance check early on. Nobody did it. B, when we did it, none of the 4 states had done it, and everybody was shocked by the results when we said to them, this is really hard to get this. And you can think about this, when somebody calls you looking for an appointment with you, how hard is it to get an appointment with you? It's hard to get an appointment with you. And imagine this population where we always say low barrier, get them into care. It's super hard. So there's a little qualitative thing, and there's 1,000 of those that come out of a study like this. Yeah, exactly. Yes, last one.
Yeah, I just have a quick question. So, you know, this is a huge effort, $350 million, right? Massive. And you sort of enter this talk telling us that you don't really know sort of what the outcomes are yet. You don't have any data on it. I was just hoping you can maybe reflect on, like, that much money. Like, do you feel like that, like, something good is, I mean, what if there is only like
You
a
want me to be a
3%?
taxpayer today? You ready for me? You ready to talk to me as a
I'm just
taxpayer?
curious,
Okay.
like, 'cause it's,
Turn off the recorder right now.
for so much investment in this, I mean, what are the other things that are, besides just whatever the percentage decrease in opioid overdose deaths that you'll see at the end of year 5 or whatever?
That would make us happy.
Yeah, yeah, or just even, I mean, do you feel like just the money invested in these communities is, like, in and of itself sort of good use of money?
So it's always counterfactual, right? The question is, what does that 350 go toward otherwise? Does it go toward, 25 investigator-initiated trials to look for more EBPs? I don't know, that doesn't seem so great to me. Like, what really would work here? What would it have gone better, as I said, for 4 different models of intervention, and then we can offer the 4 results and let somebody choose, all of them probably underpowered. Okay, that's something. It really comes down to so much of how we make evaluations of any program. There's very few evaluations of any government programs ever, as we know. It's the secret, dirty secret of all programs, right? So to actually be part of the dirty secret I don't love, but I wouldn't have done it particularly this way. There are lots of shortcuts that I would have done, but I'd never done something at this scale. So I'm not sure how differently I would have done it, but I would have done it 1,000 small cuts differently, but as a big swing, which is what the Congress does when it gives out this money, I'm not sure it was so bad. As I said, my real worries are three. One is what's sustainable in this community, is what's disseminable, and what's the threshold that all of us as a sort of community of scientists would agree makes this worth disseminating. Because I'd be stunned if there's a 40% overdose reduction. And of course, we did this in the middle of a pandemic. So all of the interventions, you have to imagine, were a bit hurt by that. So if it were done in a real way, what might have happened? So, that's an undermining of the problem. But as I said, if there's an 11% reduction, should I want to pick that up in Oregon? Do I go to my legislature and say, give us money because this is an important problem? But to me, these policy issues are always, what's the counterfactual, and are you willing to spend any money to evaluate it? And I learned this a lot running this communications core, where advertising and the effects of advertising are a complete black box. I mean, maybe Burger King and McDonald's know, and that's why they keep advertising against one another. But I can tell you, at the sort of health intervention level, it's a black box. When you go back and talk to all of the communication scientists who have run major tobacco campaigns, et cetera, they don't know. They really don't know. And so somebody here maybe can tell me that I'm wrong, but that's my impression, having done, quantitative science my whole life. The communications field is tough. It's really hard. So as a taxpayer, I'm not sure.
Thanks.
for a great talk. We have food out in the pseudo patio. Everybody is welcome to stay, except those on Zoom, but thank you for joining. Yeah.